Okay, in this section, we're going to talk a bit more about theories of pain, specifically gate control theory and neuromatrix theory. And so we already introduced what gate control theory is, right? That there's this mechanism in the spinal cord that can open and close to upregulate and downregulate the experience of pain. And this theory has a lot of strength, right? This is for a long time has been the dominant theory of how we understand pain, really revolutionized research on pain and how we treat pain, right? So really understanding that it's not a one-to-one relation between the extent of bodily damage, that pain signals can be modulated by all kinds of factors, both from other physical stimulation as well as because of psychological, emotional, and motivational factors. And so these top-down signals from the brain. And so it helps to explain why we might have injury without pain, right? If there's a huge burst of adrenaline that's closing that gate, and so that can explain that. It also explains some of the role of emotions in the pain experience, right? People like me who tend to catastrophize things and are a bit over-emotional, we experience pain really strongly and have often very low pain tolerances, and this can help to explain that role of emotions in pain, even within individuals, right? When you're feeling more emotional and more stressed about something, then you're often likely to feel more pain in that case. Although this is not always the case. Sapolsky talks about stress-induced analgesia versus stress-induced pain, right? So sometimes when we are really stressed, we don't feel pain, right? That's the example of, when there's this really acute trauma and maybe we get this big burst of adrenaline. This is a time when stress can lead to less experience of pain, right? This would have been very adaptive for that zebra who's been injured but might still have a chance to make it away from that lion, right? We want to suppress that pain signal to allow it to have a chance to do that. But other types of stress, this more sort of low-level chronic psychological stress, this can lead to more experience of pain as we catastrophize and focus on and dwell on the potential source of that pain. And so gate control theory really helps to explain these phenomenon. It really brings to the center the role of psychological factors in the experience of pain. And again, this was really a revolutionary finding, right, that we can downregulate as well as upregulate pain based on people's psychological state. This helped to explain some of the findings that hypnosis and getting people into a more relaxed state and giving them the suggestion that they wouldn't feel pain, why that actually does work in many cases to dampen pain responses. Right? So it takes into account the role of these psychological factors, and so really brought on all kinds of new possibilities for intervention. Right? If we thought that pain is just a one-to-one signal based on the extent of injury, then really our only option is to try to treat that injury, and certainly we always want to do that as well, but that doesn't take care of all pain. And so this gives us more routes to treating pain, right? We can work on psychological factors as well as other top-down signals. And also we can engage in things like massage to relieve certain types of pain now that we have an understanding of how these gates open and close. Some of the weaknesses are that it doesn't explain some types of chronic pain, where there doesn't seem to be any nociception that's occurring anymore, right? It doesn't seem to be a site of injury at this point, and so it doesn't always seem to explain that particularly well. It certainly explains some types of chronic pain where there's sensitization of certain neurons in the spinal cord due to the pro-inflammatory cytokines, but some other types don't seem to be well explained by this. One of the curious types that Sapolsky talks a bit about is fibromyalgia. We're still just starting to gain an understanding of how that pain circuitry works. And so gate control theory, at least as we understand it and fibromyalgia now, doesn't clearly explain how that works. And then really the quintessential and strongest example of where gate control theory breaks down or doesn't fully work is the example of phantom limb pain. Right, and this is something that fascinated Ronald Melzek early on, and so had been grappling with this from the beginning, and isn't really able to integrate it within gate control theory. Right, in phantom limb syndrome, this is occurring among someone who's among people who've had an amputation of some appendage, right, a limb of some sort, and then they still feel like that limb is still there at times, and they're experiencing pain in that limb, right? It might feel like their leg is twisted if they've lost a leg, or like their toenail is being peeled back. There's all kinds of weird sensations that can occur, even though, right, there is no longer a source of injury. There once was, but now that leg is gone, that wound is healed up, and presumably the person should be fine now, and they should not be experiencing pain in that limb. And so, how can we explain that with gait control theory, right? There's no signal at this point, presumably, to up or down regulate. And so to try to account for this, this is where Melzack gets his idea of neuromatrix theory, which we'll introduce in just a minute here. But just to put the slide up for this, right? So phantom limb pain, this is the experience of chronic pain in a part of the body that's now missing. And fascinatingly and horribly, this reports of this vary, but it seems to occur, at least to some extent, in up to 90% of amputees experience some type of phantom limb pain. And it's particularly pronounced among people who have lost that limb in a really traumatic way. Certainly it's always traumatic to lose a limb, but it's different if you have that blown off by a landmine versus removed while you're under anesthesia, and people seem to be more likely to experience prolonged and intense phantom limb pain when they've lost it in a traumatic experience like that, where there was a lot of pain and trauma potentially associated with that initial experience. And so, right. So again, this doesn't really work well with gait control theory. There's no impulse that's coming up from this area anymore. So why are we experiencing this? And there's some understanding of how this works now, right? So what's one thing that's occurring is that there's no longer any input to that part of the brain. To that part of the somatosensory cortex that's devoted to that body. So say you've lost your leg, you still have in your somatosensory cortex an area that's devoted to that leg, and it's used to getting input, but it's not anymore. And so it gets really sensitive as it waits for more input, and it can start to fire randomly on its own, and you can get all these weird kinds of sensations due to that. And so there's a lot of interest in how we can treat this, right? There's no direct way to treat it with painkillers, right? This is occurring in the brain itself. And so one really fascinating type of therapy that's been developed is what we call mirror therapy. And it's not what you see here, but you'll see a video that's linked here that explains more about it. But essentially what we're taking advantage of is in cases where people have lost a limb that you normally have two of, what we can do is we can put a mirror up so that, say that I've lost my right arm, we can reflect the image of my left arm so that it looks like my right. And if I clench and release that, we can basically trick that somatosensory cortex into thinking that it's getting some stimulation, and so therefore calm down its overactivity and reduce the phantom limb pain. And this has been wildly successful in treating phantom limb pain. So you can, both of these will be linked in the on the weekly page. The first video talks about an actual scientific approach to this and goes through, interviews doctors and patients who are using this approach. And the second one talks about the same idea, but from the show House. And if you've ever seen that, it's very dramatic, but I put it in here just for fun. You can see sort of the dramatic version of how this works. Of course, he has to kidnap the guy before he does the therapy on him, but it's interesting nonetheless. So that's just for fun, but if you want to watch that, you're welcome to. I think you'll get a kick out of it. So again, phantom limb pain doesn't really fit into gait control theory, and so we want to try to find a way to account for that. Right? There's no signal coming in, but so where is this coming from? And so what neuromatrix theory says is the idea is that we have these networks of neurons and in our brain, and that these form our representations of our unified physical self. And that sounds really philosophical, but really what he's just saying, right, is that we have a representation of our body in the brain, that we have a network of neurons that represents our body in physical space and our sense of our self as having 2 arms and 2 legs and about this tall, and I know, how my body is represented in physical space. And so he calls this unified conception of your body the body self neuromatrix, or we often just refer to it as the neuromatrix for short. And so really what he's just saying is that we have this conception of our physical self, and this is genetically determined, but it can be modified by our experience, right? And so, I might have a sense of myself in one way, but past experiences of extreme pain might lead me to experience my body in a different way. Also, ultimately, after, losing a limb over time, you might modify that body self neuromatrix to recognize the self as, not having that limb anymore. But initially, when you lose a limb, for example, you still have this body self neuromatrix that includes that, and it's stored these characteristic patterns of activation that you've experienced over time, and these can be reactivated, right? So you've had past experiences of hurting your leg or bumping your toenail, and all of those are still stored, and that these can become reactivated. When, again, that areas of the brain is not getting a lot of stimulation, these neurosignatures can be reactivated, and this is what can cause that pain. And so, again, these neurosignatures are stored for our pain experiences, and so they can be reactivated without any sensory input that's new. And this can occur for phantom limbs, and in theory, this can also occur for any other type part of the body, even if you still have it, right? There may be no new sensory input, but you could potentially activate still that neurosignature and have a pain experience from that. And this can help to account for other types of pain that seem to occur without sensory input, that there's these neurosignatures that can be impacted. I think this theory can often be a lot to grasp, right? It's a lot of fancy words. And as he says himself in the video you watched, this is really a theory that's still without a physical model, right? It's not like we can look in your brain and see your neurosignatures, but this makes theoretical sense. Certainly we have memories and they form patterns of activation in the brain, and so it is plausible and possible that these, can be reactivated and lead to experiences of pain without sensory input, and can also lead to additional activation of pain, right? You might have some sensory input, but it activates also a neurosignature that's stored from a past experience, and therefore you have a more extreme experience of pain than you might have otherwise. And so this is not contradictory necessarily to gate control theory, but is really more of a follow-up on it, that in addition to these gates that up and down regulate pain, we may also have these stored neurosignatures based on past experiences that can impact that gating mechanism as well, and also activate on their own, right, and create that experience without any new input. This is the image that's often used to depict neuromatrix theory, and again, looks very complicated. I think we love to make fancy figures. This is, I think, is a beautiful one, but really just to break it down briefly, right, what they're saying is that there's cognitive and sensory and affective components in this body self neuromatrix, right, in keeping with what we've been talking about with pain, right? There's cognitive related brain areas that are involved. There's emotion related brain areas like the limbic system. There's sensory systems, right? We get input from our nociceptors on our skin. That's what cutaneous means, and our visceral, our internal organs, as well as our musculoskeletal inputs, right, from our muscles and our bones. Right? We can get sensory input from that. We can get memories and past experiences and attention, emotion-related brain areas, but all of those are inputs into this body self neuromatrix, right? These cognitive and emotion would be these top-down inputs, and the sensory signaling systems would be the bottom-up. And so all of those, are active together in the brain and part of this body self neuromatrix, and this outputs our pain perception, which is what we're really talking about in this lecture, right? Our sensory and our affective and our cognitive experience of having pain. And then it also, we haven't really talked about this, but can also impact our how we respond to that pain. And that's a really important part of the theory as well, right? Our past experiences, as well as the experience of pain itself from this sensory signals, impacts our voluntary and our involuntary action patterns that follow from that, right? We might have an involuntary muscle reflex, or we might voluntarily decide to retreat and withdraw from a source of pain or stress. It also can impact our stress regulation and things like that, right? And so we've talked a lot in this class about cortisol and noradrenaline and endorphin levels. These can be impacted by our memories as well as our emotions that are related to pain, right? If we're feeling really under threat, we're more likely to have this influx of cortisol and adrenaline activity, right, to help us to escape from that stressor. And so these things all relate to one another. But again, all this is really saying is that we have some inputs, and these can be top-down or bottom-up inputs, the sensory signals or past memories and experiences or emotions that we're experiencing. Those all form together this body-self neuromatrix, and then that outputs our perception of pain as well as our reactions that follow from that. And so that's really the level that you want to understand this at. Often when I teach this, I explain it as kind of have to imagine that your stoner friend is telling you about this. It's like, dude, we totally have a representation of ourself in the brain, and it's called the body self neuromatrix. And things that happened to you before get stored there, and then they can get activated, and it can lead you to feel pain even when nothing's happened to your body. Bro. But that sounds stupid, and I put it like that, but really that is kind of what this is saying here, right? It sounds very stoner-esque, but really this theory is that these psychological and emotional factors in past experiences do influence our experience of pain, and that's really what the key takeaway point here is. So I hope you enjoyed my stoner voice. And so I tried to find a better reference to replace this, because I'm not a fan of J.K. Rowling anymore, even though I've long identified as a Hufflepuff and a Harry Potter fan before that. But this is a really, really apt quote for talking about pain. That this comes from Harry Potter, of course, so of course it's happening inside your head, Harry, but why on earth should that mean it's not real? Right? So sometimes in sort of lay terms and in conversation, you might hear people talking about real pain and pain that's in your head. And what I really want you to take away from this lecture is that all pain is in our head, right? We talked about nociception and the process by which physical stimuli get carried up to the brain, but we also learned that we can have the experience of pain even without any physical input. And ultimately, even if we have some type of physical injury, right, if you have deficiencies in your nociceptors, like we saw with people with congenital insensitivity to pain, then you won't have the experience of pain. And so pain is always all in the head. And of course, it is also very real. And so it's important not to be trying to make the distinction between pain that's in your mind versus pain that's not in your mind. All pain is ultimately in our mind, and that has important key impacts on the extent to which we experience pain, whether we experience pain that's in relation to the physical injury more so or less so. So in this last section, I just want to talk about treating and coping with pain. And really we can map these ways that we'll talk about treating and coping with pain back onto the different stages of nociception. Right? We can treat pain at really any point in this process, at the stage of transduction, at transmission. We can treat it at the level of the brain by interfering with neurotransmitters. And we can also impact it in terms of modulation in the spinal cord. And so I've organized these. These are many of the ways in which the medical treatments we use for pain, and I've organized them from really where in this transmission process they occur, from most peripheral to most central nervous system, right? So from the source of the potential injury up to the brain. And so what we can see here is that ibuprofen and acetaminophen, right, some of the typical over-the-counter drugs that we might take for pain. Maybe you've sprained your ankle and you decide to take these. These target the tuning chemicals that we talked about that operate at the site of an injury, and it dampens these the nociceptive signals that are overactive due to those. And so this is why these are particularly effective when there is a source of injury, there is a particular part of your body that's injured, and it doesn't have to just be injury, right? It can be inflammation, which is an indicator to your body that there is something wrong there. And so when there's inflammation, that can also lead to tuning chemicals, and so ibuprofen and acetaminophen work really well for that. Local anesthetics operate another level higher, right? So these are things that you might rub on a part of the body or inject into a part of the body, and these block transmission to the spinal cord, right? So they're blocking some of those peripheral nerves, and so that nociceptive signal is still occurring at the site where you might be operating, but it's not going to reach the spinal cord because you're blocking it at the peripheral level. And so that's what local anesthetics does. We can also block pain signals at a higher level. We can engage in what's called dorsal column stimulation. The dorsal column, for our purposes, is the part of the spinal cord where this gating mechanism is occurring, right? So there's different nerve fibers that can interfere with each other there. And so what we can do is we can basically take advantage of that and artificially stimulate, or what we call counter-irritation. We can stimulate nerves and fibers in that spinal cord to block the ones that are transmitting pain. And so this can block the transmission up the spinal cord. Very, very similar procedure is called stimulation-produced analgesia. That literally just means that we're stimulating you to produce the lack of pain. And what's happening here is that it's stimulation just higher up. Now we're operating at the level of the brain stem as opposed to lower down in the spinal cord. And so this is effective for types of pain that might be operating also in the spine, right? We need to block it at an even higher level. Opiates are operating at the level of the brain, right? So these are things like morphine, codeine, also heroin. That's not a drug I would recommend using for pain, but that's how it was originally derived. It's very similar to the opiates that we use to treat really severe pain, particularly when people are hospitalized. And these also block pain signals at the brainstem as well, and so therefore prevent or dampen the experience of pain, right? They close that gate. And these are created, right? These are drugs that we administer to people, but they're designed to mimic our endogenous opioids that we talked about, right? That word is really similar. Oid means it's created internally, and the ets is something that is synthetic, and so we create opioids ourselves, and we treat people with opiates. And so, again, these look very similar to chemicals that our body creates itself to block pain. And so here we're artificially administering this. Acupuncture I've added to this list, and there's just fascinating research around acupuncture, new stuff coming out all the time. And there's just mounting evidence that acupuncture can be really effective in treating pain. It seems to stimulate the release of endogenous opioids, and so rather than taking opiates, it can create a similar type of blocking pain by leading your body to create more of its natural painkillers. And also, just fascinatingly, just as a fun fact, like you can do acupuncture on animals and it will work, and so this really helps to take away from the argument that it's just a placebo effect, because certainly animals should not be susceptible to the placebo effect. They've also done double-blind studies with acupuncture. It's hard to do this. Like, how would you not know if you have a needle in you, or how would the person doing it not know? But they devised this really cool little cylinder that like may or may not have a needle in it, and they can put it on the person, and people are worse than chance at guessing whether they've actually had a needle put in them or not. And even doing these kind of double-blind studies, there's an effect of acupuncture on reducing pain. So really, really fascinating stuff there. Lots of ways to try to treat pain with these medical treatments. There's other medical approaches that can be tried. Sometimes try to manage pain with surgery, right? And so certainly if we can repair the source of the injury, or that's a way to go, right? If the pain is due to a torn ligament or something like that, right? We can try to repair that and try to alter the pain because of that. But sometimes, right, we said that sometimes the injury is healed, but there seems to be there seems to still be activation that's occurring. Maybe nerves are damaging, and so sometimes we still will lesion those nerves and try to cut those pain fibers to try to alleviate that pain. Really, we do this as a last resort because it's often not effective. Sometimes that can even lead to more pain due to the damage to the nerve, or that pain finds other pathways to use in order to still penetrate, and so people still experience pain. And so the pain impulses can find new pathways. May not always be able to repair damaged tissue if that's the goal. Sometimes you can cause additional damage trying to do this, and certainly also it's expensive and invasive. And so this is really a last ditch approach. Talked about this a bit already, but certainly stress is related to pain, right? So we can have stress-induced analgesia. So stress-induced insensitivity to pain, and it's a real phenomenon that occurs, right? And so the quintessential example being a soldier who's been injured, but we also see this in less extreme circumstances, like when playing a sport, right? That's not a major stressor in the same sense, right? But your sympathetic nervous system is certainly very activated while you're in using your body like that. And if you're in a really competitive environment, you're likely to have a lot of those endogenous opioids in your system that are blunting that pain. I once played an entire ultimate frisbee game with the staple coming out of my cleat and digging into my foot without realizing that it was that bad. I thought I just had a little rock in my shoe or something, and I'd play till the end and took my cleat off, and I was bleeding everywhere. And that never would have happened in any other context, right? So you can really see that stress-induced analgesia in this case, and also really it's just this whole influence of the psychological factors here as well. You can also have stress-induced hyperalgesia, right? This occurs when there's hyperactivity in emotional areas of the brain. And so this is really when you're ruminating about something, and so you're then feeling every little twinge as being a sign of that, right? I think many of us are experiencing this as we go through COVID, and as numbers rise and fall and rise again, we often might be thinking like, oh, is this sore throat mean something, right? Because we're got a lot of emotions going on here. Even those of you who may not have started out neurotic, maybe you're becoming more so. It can lead to more rumination and focus on stimulation in the body, and more interpretation of that as a sign of pain, and so therefore more experience of pain. And unfortunately, people like myself who are high in anxiety and neuroticism are most prone to stress-induced hyperalgesia. And so Sapolsky talks about which will occur when. Really, the key differentiator is how stressful sympathetically, right, in terms of your sympathetic nervous system activation, is this event? Are you really getting that online such that you have huge floods of adrenaline and other endogenous opioids in your system, or is this sort of a still stressful but like lower level chronic stress without all of that sympathetic nervous system activation, particularly less of that SAM activation, maybe more of that HPA, more cortisol in your system? So when you're really ruminating on these thoughts, then it's more likely to be this hyperalgesia. So Analgesia is not experiencing pain, and I think I said this wrong before, and I'm sorry about that. It's hyperalgesia, right? So analgesia is lack of pain, algesia is pain, and so hyperalgesia is extra pain. There's also psychological and behavioral approaches to treating pain. So we can, again, this is all drawing on gate control theory and neuromatrix theory, following from that we can, because there's psychological and emotional and motivational factors that can act as top-down influences on the modulation of pain, we can take advantage of this to create interventions. So we can engage in relaxation techniques, and so coping with anxiety can help to reduce the experience of pain, right? Help to reduce some of that hyperalgesia. Mindfulness and other techniques like guided imagery and hypnoalgesia, or really just hypnosis that's focused on reducing pain. These have all been shown to, at least in some circumstances, be effective at treating pain. Right? It's not going to heal your injury, but it can really change the interpretation of that input and help to close that gate such that the psychological experience of pain is lessened. Can engage in attention-based techniques. We'll talk about more about VR on the next slides, but you can try to distract yourself, right? We do this all the time, right? If you're not feeling well, you might want to put on the TV to take your mind off of that, right? When we're dwelling on it, then we are feeling more pain. That's opening the gate, and when we take our attention away from that, that helps to close that gate. So that can be an effective way to, again, it's not going to cure pain, but it can help to manage and cope with that pain. Exercise is also a really key way to cope with particularly types of chronic pain, right? And so this may not always be possible. I'm certainly not saying, oh, you just, broke your leg, you should go running. No, but for things like chronic back pain, exercise to the extent that that's possible, and you can adapt it to your level of pain. Maybe it's possible to swim or to stretch. This can promote mobility and also help your body to release more of its own endogenous opioids like endorphins to help to cope with that pain. And so as much as it might seem like you don't want to move at all when you are in pain, for some types of pain, this can be one of the best things that you can do. And then for really, really severe types of pain and chronic pain that people are coping with for a long time, sometimes cognitive behavioral therapy can be helpful, where you can't cure that pain, but what we can do is help people to reduce some of the thoughts that they have, the negative thoughts that come up when they're experiencing that pain, like this is going to last forever, this is the terrible thing, this means that something's really wrong with me, right? We might help someone through cognitive behavioral therapy to try to confront those thoughts and change those thoughts to, this is something that will pass, this is something that I can manage. And so again, you're not curing the pain, but giving people more tools to cope with that. And this is really important for chronic pain that really is difficult to treat. There are, unfortunately, many types of pain that, unless you want to dope the person up on opiates for the rest of their life, are not we can't treat them with ibuprofen or things like that. And so we need to try to find more psychological ways to cope with that pain instead. Virtual reality, right? So this is an example of a distraction-based technique. I'm going to talk about one study that showed this, but there's been many others that followed up after this. This was just one of the original foundational studies showing the impact of putting people in a virtual environment on their perception of pain. And so what they did in this study is it was done with 11 burn patients, and this might seem like a very small study, but it's actually a lot of major burn patients to find, to have be in this study, and to be willing to be a part of this. And then in part to deal with this low power in the study. This is a within person's design, right? So each participant, each burn patient in this study is going to do all of the conditions. And this is also important, not just to increase the power in the study, but because pain is such a subjective experience, right? So it's best to look at it within person. What is their pain like when they're in virtual reality versus not virtual reality, as opposed to comparing people who have been in it versus not. This is going to be a better study. And so what they do in this study is, if you've been severely burned, a really unfortunate and painful but essential part of your treatment is what they call wound debridement. And that means that you have to scrub that wound. You have to get the dead skin, the burned skin off of that, and to help allow it to heal properly. And this is probably one of the worst types of pain that people can experience. This is one of the just worst things you can go through, incredibly painful. And so terrible for them, but if you're interested in studying pain, this is a great context to look at that in, right? And if virtual reality can be helpful for these really extreme types of pain, then it's likely to apply to others as well. And so what they do in this, right, so they spend 3 minutes, have this wound debridement while they're in the virtual world, and 3 minutes not in the virtual world. And so because this study's about like 10 or so years, maybe a bit more old now, you can see the virtual world here is not particularly high graphics for what we're used to now. But I think, again, this just makes it even more powerful that they find the effects that we'll show in just a moment here. Right, so they spend 3 minutes in this world getting their wound debrided, and 3 minutes without the VR headset on. Right, you can see here we've also come a long way in our virtual reality headsets. We can have ones without so many wires now as well, and so this is only getting more applicable. And importantly, they randomized the order of this, and so some people did one first and then the other, or the opposite, and that didn't have an important effect on the findings. And so the outcomes they looked at were, worst. They self-reported about their pain. So they said, like, what was their worst level of pain, like the max on the pain scale that they reached, the time that they spent thinking about their pain, and the unpleasantness of that pain, right? And importantly, these are different things, right? You might rate your pain as the same level, but have it really be more upsetting and more unpleasant than in other cases. Right, and so that seems kind of counterintuitive, but you could think about, like, I'm experiencing some amount of pain, and that's really upsetting and bothering to me and unpleasant, versus I'm experiencing that amount of pain and, like, I'm handling it. And so they look at that pain unpleasantness as well as one of the 3 outcomes they look at. So what they find, I put the whole table here, but you don't need to worry about memorizing any of those numbers. But what they see is that in the virtual reality condition, the worst pain that people experienced dropped from being rated as severe to moderate, right? We can see here this is their worst pain. In the control condition, it was rated as an average of 7.6, and in the virtual reality condition, people said it was only about a 5, and so that's a significant difference. The unpleasantness of the pain was significantly reduced in the VR condition. So this is the unpleasantness there. It went from about 6.7 to 4.1. The time they spent thinking about the pain was really significantly reduced from 7.6 to 3.6. And just as a manipulation check, right, they had more fun in the virtual world than they did not in the virtual world. I think that should be obvious. And importantly, what was really fascinating as well is that this effect was greatest for those who experienced more presence within the virtual environment. And what they mean by presence is that they were more immersed. They felt more like they were really in this snow world, as they called it. Right? It was you shot snowballs at snowmen. That was the premise of the virtual world. And so this effect was greatest for those who experienced more presence, right? So that's dose-dependent response here, right? People who were sort of more in the virtual world experienced more of a lessening of the pain effect, right? So that's what we're looking at here. In B, these are patients who had the highest levels of presence in the virtual world, and we can see that their scores show a bigger drop than people who had lower presence, right? So they had higher worst pain, but it didn't go down as much, 8.1 versus 6.8, whereas here it went from 7.2 to 3.7. Those most immersed their unpleasantness went from 6.5 to 2.5 instead of those who were not as immersed from 6.9 to just 6. It wasn't even a significant reduction. So again, here we're showing that overall there's a main effect for virtual reality being effective at reducing the unpleasantness of pain, as well as the rating of the worst pain experience and the time spent thinking about pain. But this is really driven by the people who were most immersed in this virtual world. And so if anything, this has become more effective as virtual worlds improve, become more immersive, right? It's much more able to experience a sense of presence when you don't have a really heavy device on your head and neck, when there's better graphics in the virtual environment, when there's less lag, when you move your head. I spent a few years studying virtual reality in grad school, and those things really pull you out of the virtual environment when they're not working well. And so that's only improved since this was done. Virtual reality can also be applied in a number of other ways to treating and coping with pain. And so first, just in terms of what we just talked about, the reasons why it's believed to work in the wound debridement study and other applications like that is through these attentional mechanisms, right? That you are paying less attention to what's happening in the physical world, and that's closing that gate, right? Your attentional resources are directed elsewhere. It's also possible that some of these virtual worlds might also contain elements that are relaxing or in some way, and so that can be a part of that as well. There do seem to be some changes in brain activity when people are in these virtual worlds to indicate that there really is less stimulation in some of the limbic system areas that are involved in pain. And as I noted before, we see this dose-dependent response, right, where people who are more immersed have this experience more effectively. And then virtual reality can also be applied in other ways in rehab, right? So often, when you have some type of injury, you have to do all types of rehabilitation that can be very painful, right? You have to continue to move that injured shoulder. And so there's been really awesome applications of virtual reality to making rehab more engaging, right? So rather than doing the same stupid exercise over and over again where you just move your arm like this, we could link that as the controller for a game, such that every time you do this, that's the shooting action, and every time you do this, this is the reloading action, or things like that, right? Where we really tailor the controls to a game to the motions that you need to do for your rehab, and therefore make it more engaging, but also less painful while you're doing that, right? Because you're engaged in this virtual world. Also, a really new fascinating application for this is to try to reduce people's anxiety before they're heading in for medical procedures. This comes out of the University of Toronto, and you'll watch a little video about this, but essentially what they do is they can create virtual environments of the hospital itself and sort of walk people through in a three-dimensional immersive way what their procedure is going to be like, what the experience is going to be like, and this can really reduce people's anxiety before surgery. And importantly, right, anxiety is an emotional and psychological factor that can impact our pain experience, as well as the stress can impact our health and our immune system. And so this has important implications for people's recovery from surgery. So that's it for our pain lecture. So thanks so much for listening, and I will see you next week.